Recognize that a lot of you guys are not pediatricians or pediatric nephrologists, but I hope that we can I can provide you with a little sense to what's happening in another ICU that's close to your town, so that perhaps you can help the people around you to kind of understand that, yes, AKI is not good for people, and it's not good for babies either. So our objectives today are to review the incidence of neonatal acute kidney injury, describe the short-term outcomes associated with AKI, some of the things that Scott talked about in mortality and length of stay, talk about just briefly some of the things that I think we can do today to improve outcomes in neonates, talk about long-term outcomes, and that should be plenty for a 20-minute talk. So across the world, 128 million babies are born. I'm not here to talk about the incidence of AKI in every baby that's out there, okay? In the United States, it's 4 million babies. In Europe, it's estimated to be about 5 million babies. And again, most are born happy. They go with the mama home after a couple days. But some aren't. Some do get sick, and some do require care, which usually is in the form of an intensive care unit. Many times so in Europe, for example, the number of patients that are admitted to an ICU is approximately 80 admissions per 1,000 live births, which differs if you're a term infant. So if you're a term infant, the incidence is somewhere about 44 per 1,000. If you're a very premature infant, it's going to be everybody, but overall, less than in infants less than 2,500 grams, about 80% or 800 out of 1,000 are admitted to the ICU. So we're talking about a lot of babies here. If you think about it, from a European perspective, it's maybe 400,000 babies who are admitted to level 3 or higher in ICU, and that may account for 5% of all admissions to any ICU in your country or in your city or in your state. Many of those kids are not what we tend to think about, critically ill patients. Sometimes they just need a little bit of oxygen for a couple of days, a little bit of sugar for a couple of days. So it's a little bit difficult when we talk about the epidemiology of AKI. I mean, and again, to try to understand what population these come from. But what I will focus on today is really some of the more severely ill patients. These are the patients who are requiring IV fluids for at least 2 days. These are the patients who require antibiotics and cardiac and thermal and ventilatory support, which we know is common, yet we don't fully understand the incidence of AKI, and we don't fully understand why, how to care for those and how to support those babies, because in studies that have looked at populations, Scott's talked about, the pediatric renal replacement therapy experience, the ICU experience with renal replacement therapy, maybe up to a quarter of patients that come in there. In the NICU, it's less than 1%. It's also important when we think about epidemiology is to try to categorize folks into what kind of a sick baby are you talking about. If you have a very, very small premature infant, we know those infants have very high morbidities and mortality rates. They sit in the hospital for a long time, and their hospital course may be such that you're talking about $1 million or €1.2 million or whatever. It's very, very expensive to take care of these patients. Premature infants who maybe just need a little bit of attention have lower morbidity. They're kind of there to just make sure they don't get sick, and they're there to kind of feed and grow, perhaps. And so their morbidity and mortality is lower, but they do have long length of stay and a lot of money that it costs. If you're a term baby who ends up in the intensive care unit, you're usually really pretty sick. So those patients will have higher morbidity and mortality, and perhaps lower length of stay, which means lower dollars. And the question is, well, what does AKI have to do with all this? It's important to recognize when you're looking at the incidence or outcomes, which population are you talking about here? So from 2009 to 2014, there started to be a good number of studies. This is an example of some that happened in premature infants that we did, as well as others, where they started to look at incidence and outcomes in these babies. And you can see that, somewhere between 20 and 40% of premature infants had acute kidney injury. And you start to see this association where you say, well, kids with AKI have more likelihood to have mortality and longer length of stay. But these small studies made up of 100 or maybe 200 babies were really too small to try to control for multiple potential confounders. And so the question was, well, certainly sick kids get AKI and sick kids die, but these studies weren't really able to show very well that AKI was independently associated with mortality. And similarly, in near-term infants or term infants, you see rates of 15%, 40%. Much of this data it differs by how often patients are being looked at. If you don't look for serum creatinine AKI or urine output AKI, your incidence of AKI in your hospital will be 0. And so some of these studies, are retrospective studies where you're not really capturing, serum creatinine on a very systematic basis. But nevertheless, you're seeing kind of incident rates in the 20s to 40s again with this increased association in mortality. So that led us to kind of gather together, and so experts in the field got together and realized that the next steps that were needed was to put together collaboratives so that we can study groups of patients. And really, we had several goals. Number one is we recognized that in order for us to make progress, we're going to need to bring the neonatologist and nephrologist together in the same room where we can, learn from one another and understand what's happening from both of our perspectives. And so 24 institutions came together. Each institution had to have a nephrologist on board and a neonatologist on board. And we came together to pool data so that we can start to look at bigger numbers and ask some deeper questions. And so so here's the 24 centers that make up the initial group of the Neonatal Kidney Collaborative. And we came together to do this study called the AWAKEN study. It's the baby aware study, for those of you guys who know AWARE study. And it was really designed in a similar way, again, trying to just collect data of what's happening in the field during these ICU admissions, not protocolizing anything that we do. We're just trying to capture the landscape of what's happening. So we didn't tell anybody how often to check serum creatinines or what to do. It was essentially just a kind of a capturing the data. And so the assessment of world AKI epidemiology study, we published the epidemiology study in Lancet Child and Adolescents back about a year ago. And so here's what we did. We took 24 level 2 to 4 NICUs, and we captured every baby that was born between January 1st and March 31st of 2014 in these hospitals. And we had pretty simple inclusion criteria. We had really, they had to be in the ICU, and we wanted to capture babies that, were more likely to get serum creatinine monitoring, more likely to get, have AKI. And so we set a pretty simple criteria that they had to be on IV fluids for at least 2 days. We didn't want the babies who were just on oxygen for a day or who just needed a little bit of sugar to kind of get them back to their mommies. And we had some exclusion criteria, really trying to weed out things like, we didn't want to capture babies who were going to get congenital heart surgery. We didn't want to capture patients who had really severe congenital anomalies of the kidneys. And we used the neonatal AKI definition, which you'll see is very similar to, well, it is the KDIGO definition. The main differences that we have to account for was, one, what are we going to do about the reference serum creatinine value? How are we going to modulate that? What we did, as other people have, and we had done before, is we took the lowest previous serum creatinine value as we compared to each subsequent serum creatinine value to account for the drop in creatinine that you normally see in neonates during the first week of life. And then we captured urine output data, but for a feasibility perspective, we took only 24 hours worth of data. We didn't look at hourly values, so we captured what was the urine output on day 2, starting from day 2 to day 7 of life, and we called that less than 1 per kilo per hour. It's going to be called oliguria. We had support from Stu, who helped us develop our database and develop some of the infrastructure. And then we had some support from my center where we were able to kind of coordinate some of this. But importantly, none of the centers, the other 22 centers, really were paid by any of us. We didn't have any money to pay people, so everybody really kind of pitched in and they figured it out. Some people used residents or med students, or some people had some internal funds that they were able to tap into. But each individual center was kind of in charge of their own gathering their own support to do their data. Here's the numbers. Out of the 4,200 patients, approximately half of them met inclusion and exclusion criteria here. And we took away 140 patients who did not have 2 or more serum creatinines, nor they had urine output data. And we said, well, they probably didn't have AKI, but we took them out of the sample set. So we ended up with 22, basically around 2,000 patients in our data set. And here's what we found. 30% of the infants met the definition of AKI. And one of the things that we learned, because this was the first time that we were able to really capture babies from all types of babies, the very, very premature infants as well as the term infants. And so it was a nice comparison as we look at incidence and outcomes and risk factors. And so our cohort is made up of 14% of the really small babies, those that were less than 29 weeks gestational age, 45% of the kind of the middle cohort, and then 41% of the term cohort, those greater than 36 weeks. And you see this difference in the incidence of AKI from 43%, which decreased down to about 18%, again, in these less severely ill babies that have less morbidity and mortality. But nonetheless, no one really had talked about it. Still 20% had acute kidney injury. In the term cohort, it's back up to about 40% once again. So you see this U distribution by gestational age and the incidence of AKI. When we looked at mortality outcomes, 10% of those babies that had AKI died, compared to only about 1.5% of those that did not have AKI. So we see this kind of striking change in mortality rate in univariate analysis. Well, that's great, but can we account for some other confounders? And so we did a multiple regression analysis, and we found that even after you control for all these variables you see down here, which were associated with mortality and have previously been described as risk factors for death in neonates, neonates had with AKI had almost a 5 times higher odds of death than those that did not have AKI. So again, you're not talking about these small change or small difference. I mean, 5 times higher adjusted odds is severe as like if you had sepsis requiring multiple pressors in the neonatal ICU. And we found 9 more hospital days after controlling for confounders as well. Incidentally, I don't have it up here, but if you look at those 3 categories that I showed you and did this analysis independent for those subcohorts of infants, you see very similar findings, and you see significant changes in the odds of death through that. So the 10,000-foot view of AWAKEN is that there's a very high practice variability and variation across our centers. When we say 30% incidence, that's assuming that we caught everybody who had AKI. It's very possible because some centers very rarely check serum creatinine and documented urine output. It's very possible that there's a lot more patients with AKI that we didn't discover. And those with AKI, the difference range between one center and the other was between 3% in some centers and 56% in other centers. You can guess that the 56% group were the ones that were actually looking for it. We've answered, I think, some really essential questions that we can go back to our NICU colleagues and say, hey, listen, this disease is happening in a third of your patients and has a very significant adjusted odds. It's really not appropriate for you to ignore the kidney injury in babies any longer. And so I think we are going to change the landscape and awaken the neonatology community to this big problem. We're going to answer many more questions. We have 4 papers that have been published. We have 7 papers currently submitted for publication. And we have 6 papers that we hope to be able to kind of move along the ladder here. I want to stop here and just talk a little bit about one of these papers because I think it shares that there is things that we can do, and there's a lot of progress that we can make. And so I want to share with you one of the studies, the ancillary studies that come out, which recently was published in JAMA Pediatrics. And this is a study where we look back and ask, do patients who have infants that receive caffeine, did they have an improvement in their probability to have AKI? This has been published in single center studies. There's animal models that show that caffeine is potentially preventative against AKI. We all drink caffeine. It's generally very safe. It's been used in neonates for many, many years. And so we asked this question. Incidentally, the babies who got caffeine in our cohort were much sicker in every way you can look at, whether you're looking at incidence of comorbidities, whether you're looking at kind of severity of illness scores. So even though caffeine babies had much more likelihood to be sick, their odds to develop AKI were drastically lower. So the adjusted odds ratio was about 0.2. So we heard earlier about balanced versus unbalanced solutions, where you had to have almost 100 patients that you needed to treat to kind of save one patient from getting acute kidney injury. Here in this study, you would have to treat 4 babies with caffeine to prevent one episode of AKI. And so I think this is something that we definitely need to look at further as we move on in our world. And I think it begs the question for Dr. Ronco, should Dr. Ronco be giving cappuccino to his babies? I think it's worth thinking about. So the other thing I think we could do, and I know Stu's going to talk a lot about NINJA over time, and I just want you to glance at this data because I think it's really exciting. This is a project that we did where we basically asked our pharmacists and our doctors to pay attention when patients are exposed to to nephrotoxic medications in the ICU. And so this is, I think, something else that we will be able to do, that we have done, and I think we will be able to do more as we go forward to prevent acute kidney injury. So this is our baseline data here. You will see that prior to our intervention to pay close attention, essentially, the team was measuring creatinine about 50% of the time that we should have, shown here in this green line. And you could see that there was a high exposures in the blue and high risk of AKI in the red here. So after we initiated what we call Baby NINJA, you can see here that in green, the robustness of them watching carefully for acute kidney injury went up. And with that, as you screened more, they were able to find more AKI in the hospital here in red. Over the next 18 months, what you'll see here is these red little bars go away. And so you could see that just by asking people to pay attention, to be judicious about nephrotoxic medications, we were able to reduce the incidence of AKI. And I bring that here because even though this is a talk not necessarily on therapies, but I think that the concept that we can't avoid these bad outcomes, I think, is false. And I think this is an example of that just by carefully paying attention, we can improve the care and the outcomes of our patients. Briefly, I just want to show a couple of slides looking at the association between AKI and CKD in the neonatal population. This is some data from the past that, and there's been several case studies. This is one that shows that, yes, some patients have an improvement in their GFR after, months after AKI, but you could see how over time they can drop their kidney function. And this is, likely as they run out of renal reserve and they become bigger and bigger people, their kidneys kind of just are not able to keep up with the mass that are needed to be removed. It's important in if you look at long-term outcomes of NICU graduates that you recognize that they're born with lower nephron numbers. And so if you take away the whole question of AKI and just look at patients who are premature, born less than 2,500 grams, and you look at them when they're 18 years of age, they essentially have about twice the likelihood to develop albuminuria, chronic kidney disease, and end-stage renal failure. Whether that has anything to do with AKI or not, we're not certain at this point, but your patients who are leaving the NICU after prematurity are at risk for CKD. And these studies really don't represent the care of the patients that we're taking care of now. These are kids that were less than 2,500. We don't have 18 years of data on infants that were born at less than 1,000 grams. And it's my hypothesis, as well as others, that this number, this odds, 2 times higher odds of CKD is probably going to be more in the 4 to 10 times higher odds of CKD when they reach 20 years of age, and there's really tiny X-preemies. There is some data looking at this. This is some data that compare term infants versus extremely low birth weight infants, and it's been shown that they have lower renal volumes, higher cystatin Cs, and higher urea levels, even at 7 years of age. This is a study looking at AKI in patients who underwent ECMO, and what this is a beautiful study where they really captured every single, or most, I think it was like 90% of the patients that were on ECMO, they had follow-up data up to 8 years of age in the Netherlands. And so it's one of the best studies in that it was able to really bring back a huge cohort of infants that had 65% incidence of AKI. And what they found was, if you combined chronic kidney disease, hypertension, proteinuria, patients who had AKI had 4.3 times higher likelihood to develop CKD than those patients who did not have AKI during their NICU course. The other study I want to mention, this is a study called FANCY. It's a small study which only brought back 34 very low birth weight infants. But what I want you to see here is that if you were an infant who had acute kidney injury, who was a premature infant, your rate to develop at least one sign of chronic kidney disease was 65%, which was higher than 14% of those who did not have a documented episode of acute kidney injury. So I think that in a growing baby who's continued to develop his kidneys, I think the probability that AKI is bad for that kidney is probably very high. Again, there's not a lot of data, and we definitely need more to understand whether it's that these babies are born with low nephron numbers or AKI or the combination, and we'll hopefully be able to understand that further as we continue to move. Finally, I just want to mention one more thing about outcomes, and I'm going to leave the details to go to Dr. Zacharias Ricci as our next speaker, but I do want to say that I think outcomes will get better as the therapies and the support and the ability to care for these babies improve. The biggest thing that is going to change, at least it has in our program so far, is that you're going to be able to put these babies on a circuit without it being a big deal, where your families aren't anxious and your team isn't anxious and the baby just kind of goes on circuit. And in our program, we've been able to do that with a different machine, and we very rarely have to tinker with anything after we put them on initiation. And I know Zacharias will be talking about the Carpe Diem, and you guys have all seen it, and there's other machines that are being developed as well. So in summary, neonatal AKI is common. Those with AKI have worse outcomes, even after controlling for potential confounders. And there are risks for chronic kidney disease. There's a lot of work to be done, and this is truly an exciting time in the field, because I think we're right on the cusp to be able to really make some really important strides and changes to improve the care of these babies. And with that, I thank you very much.